Hi, I'm here with the incomparable Rishi Wadhera, who's put together with his team a great piece on private equity and cardiology that's presenting at the Academy Health meetings. Rishi, tell me a little bit about this paper.
Yeah, thanks so much for having me, Harlan. Across the country, I think we're seeing financialization and corporatization of healthcare, and I think that's a shift that's going to have major implications on how we practice as clinicians and the care and health of our patients. And private equity firms are just one example of that. And these firms basically use capital from institutional investors to invest in private companies like healthcare entities, cardiology practices that have the potential to return profit. And these firms typically try to add value to companies within 3 to 7 years and then sell their stake, ideally at a profit. And so the rapid growth of private equity in healthcare has really attracted a lot of scrutiny from the public and policymakers. And that's because there's just significant concern that private equity firms' incentive to generate financial returns on their investments rather quickly might lead to changes in the way care is delivered that adversely affect patient outcomes. And what we've seen in other medical specialties, the evidence has suggested that private equity acquisition leads to increased costs, decreased quality, reduced staffing, and greater use of profitable service lines. But what less is really known about how private equity's presence in cardiology has grown. And there are many reasons to think that cardiology might be very attractive to these firms.
What was the major finding? What did you find in this study?
So what we found, we looked over a decade between 2013 and 2023, and we basically found that there were 342 acquisitions of cardiology clinics across the country. And really the vast majority of those acquisitions, 95% of them, occurred between 2021 and 2023. And private equity acquisitions of cardiology clinics happened in 20 states. Florida had the highest number, then Texas, then Arizona. And a lot of these acquisitions were highly concentrated in the same areas within these states, possibly because these firms intentionally try to develop market power to increase prices for cardiovascular care. We also found that private equity firms were more likely to acquire cardiology clinics in the wealthiest communities, but that there weren't really any other associations between other important community characteristics and the likelihood of acquisition. And those other characteristics were levels of educational attainment, rurality, and the percentage of racial and ethnic minorities living in a community.
So this is a sea change. I mean, I don't remember a decade ago talking about private equity coming in and buying cardiology practice. We did hear about health systems acquiring cardiology practices. Is this a new thing?
Well, I think it's been sort of an insidious infiltration is what I call it. I think private equity has gone after sort of the lower hanging fruit practices that are easier to flip and generate profits on, like ophthalmology and dermatology. I think the reason where, cardiology has caught private equity's eye is there are three reasons, really. Cardiovascular disease is common, and we know the burden is only going to rise with the sea of cardiometabolic risk factors we're seeing and the aging of the population. Importantly, cardiac procedures are really well reimbursed, and so there's likely a lot of appeal in entering the specialty because it has such profitable service lines. And then we're just seeing this broader shift towards delivering cardiac procedures in non-hospital settings with the rise of ambulatory surgical centers and cardiology, and more procedures are being reimbursed in these settings, which private equity firms may see as an opportunity to maximize profits. And I don't want to be all negative, because the counter perspective is that many cardiology practices and other types of practices struggled financially in the wake of the pandemic. And so the counterpoint is maybe private equity firms are providing much needed resources and capital for these practices to survive and do well. And that's why we need to understand what the effects of these acquisitions will be.
But some people argue that these practices have been insulated from competition and so have become inefficient and in some ways haven't made the hard decisions about how you fashion a practice to be highly efficient, to be able to provide the services, to delight the patients. And so that if a private equity comes in with, an eye towards making this a highly efficient practice and recognizing the need to make sure that patients are happy, is there any possibility that this is actually a good thing?
I think that that's certainly possible, and that's why we really do need to closely monitor what the effects of acquisitions in the cardiology space do to quality and outcomes. But I completely agree. One argument is that not only do these private equity firms provide resources and capital that practices need to deliver higher quality care, but perhaps they're bringing expertise that these practices don't necessarily have from an operational standpoint that enhance efficiency and ultimately improve patient care. And so I think that's why there's this tension and sort of understanding what is going to happen and what are the effects of these acquisitions going to be. I will say that obviously we talk about private equity like it's a monolith, but this is a heterogeneous group of firms. Different firms may operate differently. So some may be good, some may be bad, and we need sort of a stronger empirical basis to understand what the ultimate changes in care delivery and outcomes are as a result of these acquisitions.
Yeah, kudos to your group. I mean, I think one of the most important findings of this is this with this growth of acquisition, the context of care is changing in a lot of communities. It's not the docs who are owning it or nonprofit health systems, largely sometimes for-profit health systems, but health systems which have boards and are accountable to the communities, but rather this is changing. I mean, groups are coming in, putting in capital, expecting a return, and the whole sort of face of this is becoming privatized in a way that we haven't seen before. And, at the same time that we're saying that, we need to look at ways to provide broader access, that this is a group that's going to be figuring out how to squeeze profits out of the care. And so we're going to have to be really vigilant about what's going to happen going forward. Your piece really illuminates this growth. What's your next step, do you think, in terms of this research?
Yeah, I think we're planning a series of studies to really understand, what acquisitions in the cardiology practice space ultimately do to prices, staffing. Are physicians more likely to be replaced by advanced practice practitioners? Does that improve or worsen care or not change it? What does it do to competition in the local area? So we're doing a lot of work in that space, and I'll just sort of echo exactly what you said. I think we as a cardiology community need to understand how the healthcare landscape is changing around us, because these broad shifts in the organizational structure of practices and hospitals could have a major impact on the way we deliver care every day and our ability to take the best possible care of patients and ultimately improve their cardiovascular health.
Are we seeing this in any other countries? I mean, most other countries have very different structures to their healthcare system. Have you seen this anywhere else?
Not that I'm aware of. Not that I'm aware of. In part because those health systems are so constructed so differently.
Yeah, and depended really on a more of a governmental approach to providing care largely. One other question I want to ask you, are there any government regulations and policies which constrain the acquisition of these by these private equity groups?
No, so that's actually the big. This is why congressional committees are all over this issue right now. So if you look, a lot of the U.S. Senate and House committees are investigating private equity's presence in healthcare. It's all over their radar because of the concerns we just sort of discussed about the incentive to generate profits rapidly might hurt patients. And so I think everyone agrees there's a need to closely monitor the situation and understand what the implications are for patient care and health. But I think that's the precursor to potentially some types of regulatory approaches coming through to more closely control how much these external entities can enter
the market. Need for oversight to really make sure it's safe.
Yeah, and the challenge, to be totally honest, is that many nonprofit hospitals are viciously for profit. So, private equity firms will say, I don't understand why you're singling us out. Hospitals operate in the exact same manner. We're bringing the expertise and know-how and knowledge base to actually do this well. And so, it's an interesting back and forth. And I think this is like a great example of how we really do need rigorous evidence to inform the next steps. Because I don't know, I could be convinced either way.
Yeah, so we need the evidence, and you're providing it. Okay, final point. You did this with a great team. I just want to do a shout out to some of the members of the team who contributed to this.
Thank you so much. This effort was really spearheaded by two tremendous trainees who are co-first authors, Victoria Bartlett, who is a resident at the Brigham and does research with us here at the Smith Center at BIDMC, and Michael Liu, who is another very talented Harvard Medical student. And so they, I will say private equity transactions are intentionally opaque. They did a lot of the hard work of putting together this data set and manually validating it over months and then spearheaded all this work. So
Yeah, kudos to them and to you. I mean, this really was hard work, sort of shoe leather epidemiology, where you get down, get your hands dirty in the data to create the data set, to be able to look at this, because there's no easy way to access it. Kudos to them. I love it when a trainee is first authors and then they have a great senior author like you providing guidance. It's just a great story. Appreciate this contribution. We're so happy to publish it. We look forward to your future work.
thank you so much, Harlan. Thanks for having me.